So it is my pleasure to introduce this afternoon's keynote speaker. A woman who actually needs no introduction. Dr. Yvette Roubideaux is the director of the Indian Health Service. She's a member of the Rosebud Sioux Tribe and was confirmed by the U.S. Senate as IHS Director on May 6, 2009 and sworn in on May 12, 2009. As the IHS Director, she's also presided over some of the largest increases in the urban Indian health budget than any other director in recent past. So we are extremely grateful for her leadership and her support, and we've asked her here today to give us some updates on IHS and the partnerships between the urban programs, headquarters, and the tribal programs, and we're thankful that she accepted our invitation and is here to address our conference. So with that, Dr. Yvette Roubideaux.
Well, good afternoon, everybody.
Good afternoon.
Hey. Well, it's great to see you all here today. It looks like you have outstanding attendance for your annual meeting, and I'm really glad you invited me because I wouldn't want to have missed it. And I got a look at your agenda, and it looks like you've been having some great sessions, some very timely topics, and I wish I could have been here for the whole thing, but I'm sure some of you can let me know how it was, and I'm certain that the information that you've all been sharing will be very valuable to everybody. I do want to continue to pledge my support for the Urban Indian Health Programs. You provide really critical services to the patients that we serve, and I know that the history that you've had to go through over the past has been very challenging, but this administration and I support your efforts, and I don't want you to forget that. And despite all the politics and despite all the things you hear on the news, we're doing everything we can to make sure that we can continue to provide the great services that we do to our patients. And I always have you in my mind as we're thinking about the future and thinking about the decisions that we make. So again, it's great to see you all here, and I'm looking forward to sharing some information with you, but also to hear your questions. So if you have any questions, please write them down, because I'll try to leave and have time for questions. So I'm going to give you about a 15-minute update on some maybe new information or progress that we've made, and then we'll have some time for questions. And so it's good to see everybody. Well, I think the one thing that people probably are most talking about these days is the budget for the federal government and the budget for the Indian Health Service. And as you know, we've been on multiple continuing resolutions up until about a week and a half ago, where finally a deal was struck, and we got a continuing resolution now through the end of the fiscal year for 2011. So it's great to finally have a budget, because it's very difficult for all our programs to just get small pots of money along the way. And so we're working on getting our apportionment and allocating out all the funds as soon as we can. However, even though it's great that we now have a budget for the rest of the year, the challenge we have is it's a very difficult climate now. With the new Congress, especially the new members of the House, there's a lot of conversation about cutting the budget. There's a lot of conversation about the national debt, and a lot of conversation about how it is important for all of us to share in the responsibility to deal with the national debt and to look at our resources and use them wisely. And so it's one of those things where we all have to play our part to try to help with the economic situation and the federal debt. But while it's a shared responsibility, it's also a shared opportunity for us to make sure that we're meeting our obligations and to make sure that we're trying to make progress in winning the future for our country, but also winning the future for the Indian Health Service. The budget, as you know, for fiscal year 2011, we proposed a large increase. We wanted to have a big increase in our budget to address the need that we have system-wide. But in this climate, with this Congress, it was very difficult for us to get that large increase. And as you know, many, many federal agencies had cuts to their budgets. Fortunately for us, the Indian Health Service is just slightly above fiscal year 2010 overall, maybe about 0.5%. Some of you may have seen the numbers in the budget deal. So that's not what we wanted, but compared to others, it's great. Because there are other agencies that had cuts of several $1 million, hundreds of millions of dollars. There was discussions at one point that were very serious about 2008 levels, and those conversations are still at play. And so this is a very different budget situation than we've had in the last couple of years. And while I'm very grateful that we've had increases over the past couple of years, mainly due to the Obama administration, the president's support, and our secretary's support, we're in a situation where the conversation now is about reducing budgets and reducing the deficit and being fiscally responsible and using our dollars as effectively as we can. But I want to reassure you that we are continuing to fight for the Indian Health Service. I've had many visits to Congress in the last 2 months where I continue to talk about the responsibility for Indian people, the importance of our budget requests, and the importance of maintaining clinical services. So I want to reassure you that in my role, I'm trying to do everything that I can to advocate for the Indian Health Service. And there still is a lot of support. Some of the people I'm meeting with in Congress are our old friends. They're old friends, and they're always advocating for us. And the fact that the Indian Health Service was one of the few agencies that did not get a cut says a lot. It says a lot in this particular budget climate, that Indian Health Service ended up with a tiny increase. But we're still pretty much at the 2010 levels. And what that means is that sets us back a little bit, because we normally would need to have an increase in current services to be able to maintain the level of services. We need to have our inflation, and we need to have our population growth numbers, and we need to try to increase. And I know the Urban Indian Health line is sort of a special line in the budget. And, you know, we have wanted to be able to try to get more funds in that area, and it's just been very difficult. But I want to reassure you all that we are fighting every day related to the budget with Congress. And the challenge really is with Congress. I want to really reaffirm the fact that the administration does support the Indian Health Service and sees it as a priority. The president has reaffirmed his commitment through his budget requests. And I think the 2012 budget really shows that support. The Indian Health Service, the President's budget for 2012, proposes a 14% increase. And that's in the context of an overall decrease for the federal government's budget, for the President's budget. And so there still is a lot of support. Secretary Sebelius, I meet with her regularly. She said that she still supports us and still believes we're a priority, and she will continue to fight for us in the budget as well. So I don't think there's no hope for us. I just think we're in a different climate, and I think we all have to play our part to be able to educate people about what our needs are, and to be able to talk about what our challenges are and what our needs are in the Indian health system throughout all portions of the Indian health system, including our direct service sites, our self-governance sites, our tribal sites, and also our urban Indian health programs. So I want to reassure you that the priority and the support for the Indian Health Service is still there. It's just, I think it's really important for us to acknowledge the fact that we're in a different time, and the budget battles and debate that you're seeing on TV are real, and it's something that we're just going to have to adjust to. But I continue to be excited about the work that we do. I continue to be energized and trying to make sure that we can get all the support that we need for this system. So, and certainly any of the stories of what you're doing at your clinics the heroic efforts that you're making to try to provide health care to individuals who are in dire straits, who have no other place to go, is not only commendable, it is required, it is essential, and it's something we need to support. So I want to reassure you the support for you all is still there. Nobody's mentioned cutting the urban Indian health programs, so I haven't heard anything about that, so that's good news. We haven't heard anything out of Congress related to that at all. So they're just talking about cutting us all, cutting the whole budget, and that's something we can't afford to have happen. So we'll continue to fight related to the budget and to talk about that. The 2012 budget, we also included an increase in that we had proposed in 2011 that we didn't get, and that was the money for urban Indian programs to improve third-party collections. We're still trying to get that funds. We didn't get it in 2011, but you'll notice we put that in our 2012 budget. Third-party collections can be so incredibly important, especially with all the changes in our American healthcare system related to health reform. The 2013 budget formulation is really in process now as we look at our budget. I think that it is possible that we're going to have to look at areas to save and areas to find efficiencies, but I want to reassure you that the urban Indian health program support is strong, and I know you need every single penny of the budget that you have to do the work that you do. So overall, even though the budget is a different thing, I'd much rather be up here telling you we got a 13% increase like we did in 2010. I think that, you know, the resiliency and the support and the enthusiasm for what you do is there, and our partnership only needs to be stronger as we move forward, trying to make sure that we support the urban Indian health programs. Well, we are doing a number of things to make progress and advance the support that we have for urban Indian health programs. You know, my priorities are for the agency to renew and strengthen our partnership with tribes, and we also have a version of that priority, which is to renew and strengthen our partnership with urban Indian health programs. And we have been working with NCUIH on the new provision in the Indian Healthcare Improvement Act reauthorization to establish a policy to confer with urban Indian organizations, and I'm really grateful to NCUIH for their assistance as we've been thinking through that conferring policy, and I think all of you have had a chance to look at that as well. And we're in the final stages of preparing to publish this policy in the Federal Register for comment, which is something that we need to do. And that will give everybody an opportunity to get one last look at it and to make sure it's right, to give us the comments that you need so that we can begin the implementation of that formal policy that was a really great outcome of the reauthorization of the Indian Healthcare Improvement Act. So thank you so much for all of your help in getting that policy together. I really appreciate it. I know that it's critical because it establishes the formal relationship that we'll have in terms of conferring and working on issues together. There are another consultation that we're having with tribes, which I hope you all had an opportunity to give input on, is the Special Diabetes Program for Indians, the 2-year extension. We've been asking, you know, what should we do with the distribution formula for the 2-year extension? Should we keep it the same or should we change it? And the overwhelming input that I've heard is that, you know, the programs are doing great. Everybody really doesn't want to sort of disrupt everything for just 2 more years of funding. And so the overwhelming input has been to keep the distribution the same and to have more of a continuation rather than a competitive process. And so I'm close to making a decision on that, but if it's just a 2-year extension, why not just keep everything the same? And I think stability in funding right now is a really important thing. So I think that, I don't know if all of you, but many of you, all of you have a special diabetes program for Indians funding? Okay. So we're looking to just kind of keep things the same, which is probably a relief, I would think. So we'll have a formal announcement of that soon, but we continue to fight to keep that funding going. Well, one of the things that we'll need to have a conversation about is the urban conferring policy establishing the national relationship. Phyllis, I can't remember, did we put anything in there about conferring at the area and local levels as well? Or we did? Okay. So one of the things I'm doing in IHS is making our employees be more accountable by putting certain things in their performance plans that they have to do, so that if they don't do it, then I can hold them accountable. And we put the consultation requirements in the performance plan, but I think it'll be our job as we get the conferring policy in place to put that in the performance plans of all the agency leadership, so that to make sure that in addition to nationally, the areas are conferring with urban Indian organizations as well. And so we'll work more on that. It would be helpful for us to know, what would be the evidence that our areas are conferring with you in a appropriate way, and how we can sort of check and make sure that they're doing a good job. Well, the second priority is to bring reform to the Indian Health Service. And we've been doing a lot to try to change and improve the Indian Health Service. And we have to do a lot. As you probably had in your discussions here at the meeting, the U.S. healthcare system is changing, and the environment within which we provide care is changing, and so it's going to be really important for us to find ways to be competitive and to provide the best quality of services, so that, if our patients get access to more health insurance or get access to Medicaid coverage, that they stay with us rather than go off and use other healthcare resources. And so we've been having quite a number of conversations about the impact of the Affordable Care Act and how that's going to impact the Indian health system, and really encouraging everybody to learn about the new changes as much as you can. And we gave funding to NCUIH to help us with outreach related to that. I understand there's been some sessions on that, and I think it's important. It's going to be such a great thing for American and Alaska Native people to have better access to quality, affordable health care and healthcare coverage. So you've probably heard with the Affordable Care Act that by 2014 there's going to be the state exchanges. The state exchanges, if a state chooses to establish an exchange, it's basically going to be a health insurance marketplace where the individuals of the state can go to a website, and it's going to be like Travelocity or Expedia.com where you can go and buy a flight. This is going to be a website where you can go and buy health insurance if you're an individual or a small business. And what it's going to do is all the insurance plans that participate in the state exchange have to put all their information up on the website. So our individual American and Alaska Natives can go to that website, can look at all the choices, and then can choose the most affordable, to purchase the most affordable health insurance if they're able to do that. And if they can't afford it, they'll also check them for eligibility for Medicaid. And as you probably know, that by 2014, the income to qualify for Medicaid is going to go up to 133% of poverty level. And you're going to, all the unusual conditions you needed to qualify for Medicaid are going to go away, because it's really going to more be related to income. And so that could be very beneficial, especially to a lot of patients in urban areas which may not have access to employer-sponsored health insurance, or because of their income can't afford health insurance. And so, or their income might be slightly above the current income requirements related to Medicaid, or they might not fit into one of the different categories to qualify. But now, in 2014, they have an income up to 133% of poverty level, they would qualify for Medicaid. So many of our patients now may have access to affordable health coverage that didn't have access before. Now that would be a great thing for us, if they come to us and they use our services and we can bill for those services, because that could mean more third-party collections. However, it also could mean they'll say, hey, I got my insurance card, or I got my Medicaid card, I'm going elsewhere. And so it's going to be really important throughout the entire Indian health system, not just urbans, but direct service and the tribal programs. We have to work on our customer service and work on how we're measuring and talking about the quality of care that we receive, so that we can be able to show our patients that we really are the best choice for them. And of course, for many of our patients in urban areas, you're the only choice that really is able to provide the culturally competent care that they can find in the home base for them as Indian people, because a lot of them are away from reservations. So I think it's worth thinking about how we can be more competitive in this new health insurance marketplace. Maybe think about marketing ideas for how to market ourselves, and to make sure our patients know that we really care about them, that we are doing what we can to provide culturally competent care, and that we do provide the best quality care that they can receive. And I think that it will be worth some conversations about that. I noticed you had some conversations about sustainability, and I do think what we're doing overall with the Indian health system is thinking about what's our business plan, or our ideas about how we're going to market ourselves and improve our services in a way that our patients, when they get that health care coverage that they didn't have before, they don't walk out the door and go someplace else. And it's important for us to plan for that now. We have time, it's not till 2014, but 2014 is going to be here pretty quick. Time seems to be flying pretty quickly for a lot of things, so I hope that we can continue to have conversations about that. With the Affordable Care Act, I know there's some concern about the differing definitions in the law of Indian. We're reviewing that with the department. There's a number of questions about new things related to the law. One of the big changes that you'll see in what we're talking about with health reform is that last year we talked mostly about health insurance, all the new protections that people have if they have insurance, and starting the conversation about the state exchanges and preparing for that. And there'll be opportunities for you to comment on that. There'll be a notice of proposed rulemaking, actually probably several, over the next couple of years that will be opportunities to comment on how the state exchanges are set up. And I would be really interested, I've heard a lot of the tribal input about the state exchanges. I have to say I haven't seen very much input from the urban Indian health programs. I would love to hear your thoughts about the state exchanges and what that means for you, and suggestions that you might have. I participate in all the HHS activities related to health reform. I sit at the table where decisions are made, and it's really important for me to know what your concerns and issues are so that I can make sure that I bring those up in those conversations. I'm kind of becoming a broken record every time that we have conversations about the Affordable Care Act at the department level with all the agency heads and the secretary. I'm always bringing up issues related to the Indian people and American West Indian people and what they need. So if there's a way that we can work together to make sure that we're hearing your input and your thoughts about some of these new changes in the healthcare system, that would be very beneficial for me to hear about that. We're going to be talking more about delivery system reforms coming up in the next year, and that's a part of the Affordable Care Act that relates to improving quality and reducing costs. And you may have heard about the accountable care organizations. There's a notice of proposed rulemaking for comment out right now. Accountable care organizations are how CMS is going to work with groups of providers to try to improve quality while generating cost savings. And we need more conversation in Indian country about how our facilities fit into the conversation about accountable care organizations. So I encourage you all to look on the healthcare.gov website to find the accountable care organizations notice of proposed rulemaking and read some of their materials about what that means and what, you know, we're actually really not clear about how, for example, IHS direct sites or tribal sites or urban Indian health programs would fit into these groups of providers that are going to look at quality and look at sharing cost savings. And we're not really clear about how that's going to affect our reimbursement rates and those sorts of things. So it's really important for us all to sit down and talk about what those issues are. There's another initiative which has just been launched called the Partnership for Patients. The Partnership for Patients is an initiative that was launched by Secretary Sebelius and Dr. Don Berwick, and it has to do with reducing harm in our healthcare system. Its main focus is in hospitals, reducing hospital-acquired conditions and reducing readmission rates. But in order to do that, all the health system has to be involved. And so there may be ways that urban Indian health programs can get involved in this exciting new initiative. And so we'll be talking about the Partnership for Patients with you all soon. You may have heard in the news that there's a lot going on regarding the possible repeal of the Affordable Care Act. And that's scary for us because the Indian Healthcare Improvement Act is included in that, and there's all the Title V improvements for the urban Indian health programs. There's two activities happening related to possible repeal of the law. The first is the congressional efforts, especially on the House side, to try to repeal the Affordable Care Act. And the good news for us is it's very unlikely that the Senate will pass any of those, and it's extremely unlikely that the President will sign any of those. So the congressional conversations are going to go on about it, but we don't know the outcome of that, but we still have the support of the Senate and the President regarding the Affordable Care Act. The other area where we're seeing repeal efforts is actually in the courts. So you've probably heard there's some court cases going on. It's mostly around the individual responsibility payment, that all individuals will be responsible for demonstrating that they have health care coverage, or they may have to pay a penalty. The American Indian Alaska Native people are exempt from that penalty, and there'll be more discussions about that. And actually, I think the provision says members of tribes, and it's another one of the definitional issues in the Affordable Care Act. But these court activities and the court cases are going to continue sort of making their way through the court system, and it probably won't be decided till it gets to the Supreme Court, and that's probably months and months away. So right now, the Indian Healthcare Improvement Act reauthorization is fine. There's actually a movement in Congress to have a backup bill available just in case, on the House side even. And so everybody supports the Indian Healthcare Improvement Act reauthorization, and nobody really feels it should be included in those court cases. And so we're doing everything we can to try to protect the permanent reauthorization of the Indian Healthcare Improvement Act, because we know it's so important to urban Indian health programs. The Indian Healthcare Improvement Act, we continue to implement that. We're working very hard. We've been trying to provide updates about various provisions in the law. I know you're going to get an update on the needs assessment after we meet with Joanne Kaufman and Kaufman Associates. The conferring policy, of course, is an important part of that. One particular provision I know you're interested in is the access to federal insurance, Section 157, which allows tribes and urban Indian organizations to purchase for their employees federal insurance, federal employees health benefits and federal health insurance, and federal employees group life insurance. And so we expect an announcement from OPM, the Office of Personnel Management, actually very soon. Maybe, we're talking days for an announcement related to that. So they'll be able to give you progress on how they're doing with implementing that particular provision. I'm not sure that, I haven't really had the chance to ask Urban Indian programs. If you've seen the cost per person of the Federal Employees Health Benefits for 2011, have you all had a chance to see that estimated cost for individuals and families? For how many of you, well, actually, how many of you offer health insurance for your employees? Okay, it looks like a good number of you do. How many of you have seen the numbers and think that this access to federal insurance is a better deal than you have now? Maybe one or two. You know, I think I asked an urban audience about this before, and that this may not actually be a better deal for you all, but I would be interested in your comments once OPM actually makes this insurance available and we have more information about it, whether it still continues to be something that might not be a good deal for you. The other thing is the state exchanges. You know, one of the things that the tribes have wanted us to look into is whether tribes could group purchase insurance for their employees or members. And I don't know if it would, urban organizations be interested to see if there would be a way that you could purchase insurance for your employees through the state exchanges. Maybe we should have a conversation about whether we should look into that as an option, because the insurance might actually be cheaper in the state exchanges as well. So we'll work on that. The other provisions of the Indian Healthcare Improvement Act we continue to work on are long-term care. We had a meeting in November, and I'll be sending a letter out soon with those recommendations. The VA provisions, the sharing of facilities, and the reimbursement of IHS from the VA for eligible veterans, we're still working on the implementation of that with the VA, and we know that's a priority. So we'll keep working on that as quickly as we can. So those are some of the highlights of the Indian Healthcare Improvement Act implementation. I want to reassure you we're working as quickly as we can, as carefully as we can, and if you're ever interested in submitting input around any of the provisions that relate to you in the Indian Healthcare Improvement Act, you're welcome to just send me a letter or send me an email, and we'll factor in your input related to that. I'm going over time, but let me just do a real quick summary of other reform efforts. We're doing a lot to change and improve the Indian Health Service, and we're working on reforming the way we do business. And we've done a lot of improvements in our financial management and the way we do a number of business operations. We've been working on hiring and recruitment. We've been improved our property management greatly. We've been improving our performance management and customer service. And we're definitely doing a lot to improve the way we do business. And I think that goes along with your conversations about sustainability. A lot of people view the Indian Health Service as a service, and that it's something that people come to work at with a great ethic about service to Indian people. But healthcare is a business, and it's been a real big priority. You know that more than others because you have a bottom line. But I don't think a lot of people in the Indian Health, for example, direct sites, understand the fact that we have to be a business. We have to balance our budgets. We have to do things in an efficient and effective way. And I know that you know that every day. You're living on a wing and a prayer sometimes. I understand that. And so you already know the importance of the business of healthcare. But our direct service sites are needing a lot more attention and education about that issue, and we're working on those reforms as well. Improving the quality of and access to care. I'm glad some of you are involved in the Improving Patient Care Initiative, our patient-centered medical home initiative, and really look forward to ideas about how we can do that in more urban sites. And I really think that that initiative is going to tie in well with all of the new health delivery system reform initiatives and the Affordable Care Act. We also signed a memorandum of understanding with the VA last year, and we're going to start working on how to improve working with the VA locally and making sure we're coordinating care for our veterans between the VA and the IHS. And I know that many of you have VA systems that you interact with, and so I'm interested in your input on that as well. Let's see. We've been working a lot with HRSA. Dr. Mary Wakefield and I meet pretty regularly, and our staff have been working hard on making sure that some of the resources HRSA has are made available to our facilities. One of the most important things is the National Health Service Corps. I don't know if all the urban Indian health programs are eligible for the payback, the loan repayment and the scholarship, National Health Service Corps. And if you're not, talk to Phyllis, because we've been working with HRSA to try to get all of our facilities eligible as to the extent that we can, because there's a bunch of new money in the Recovery Act and a bunch of new money in the Affordable Care Act that's going towards paying for more of these National Health Service Corps doctors, dentists, and behavioral health providers. And so we definitely need to make sure that we're taking advantage of those new resources available to get more healthcare providers. So let's have more conversation with Phyllis about the urban Indian organizations. The last priority is making everything transparent, accountable, fair, and inclusive. I've just been doing a lot to try to do more communication about what's happening in IHS. I hope you get a chance to go to my director's blog. I put pictures of the meetings I go to, and we'll try to put a picture up here just to let people know what we're up to. And that's also the first place to find information. I put things there before we post press releases. I put things there that we wouldn't normally, put out. And it's important to check that blog every once in a while so that you can get more information about what's going on. I've also asked our areas to give more information about what's going on in the areas, and I've asked them to send emails to their staff and to their major stakeholders, so I need to make sure that they're sending you emails as well about updates in each of the areas. And inclusiveness, I want to reassure you, every decision I make, I think of you. I'm making sure that our decisions are inclusive of all of our sites, whether they're tribal, direct, or urban Indian programs. I'm glad that also, I think maybe you've heard the news that the IHS RPMS, our electronic health record, just got certified, and it's the first federal system to receive certification. And so for those of you who use RPMS, I hope you realize now that that is one step in being able to try to get the Medicaid EHR incentive and Medicare EHR incentive payments. But since you're all clinics, it's probably Medicaid is going to be the one that's more advantageous to you. So I hope that I saw that there was a lot of discussion on that in your agenda. And I'm really grateful to see that you're looking at that issue. Let's see. So anyway, that's the update that I wanted to give. I think it was a little bit longer, but if your agenda can stand it, I can stay a little bit longer for questions if you'd like to do that. Okay, great.
Run microphones, please. Questions? Somebody's got to be first.
Be brave. I just gave you a lot of information. Sorry I didn't have slides today. Things are changing so fast, it's kind of hard to keep up with a slide set. So,
when we go through insurance and we take a look at personal insurance, you do some.
It's on you, Scott.
We have to take a look at some comparisons with other organizations. Has IHS ever done that with their insurance to see what the comparison is with other providers to see the cost effectiveness?
Well, IHS technically is not health insurance. It's healthcare for American Indian Alaska Natives. We don't have a defined benefit plan. So the way that each facility provides the services that it can that are available, so we don't really think of ourselves, we think of ourselves as a healthcare provider, but that we're not providing health insurance. We've looked at the cost of care, we've looked at the per capita expenditures, the per person expenditures, and if on healthcare in IHS, and if you compare that to other federal systems, and you compare that to the VA, or you compare that to even the prisons, our per capita expenditures or per person, the amount of money we spend on healthcare is lower than everybody else. So in terms of cost effectiveness, we're already spending less than everybody else, so it's hard to talk about cost effectiveness. I think what is probably more helpful to think about is looking at the services that we're able to provide in our different facilities, and trying to compare that. What's going to happen with the Affordable Care Act with the state exchanges and Medicaid, the law is defining minimum essential benefits, which is going to be the minimum level of benefits that those health plans and Medicaid has to provide for the people who use those health or purchase those health plans or use Medicaid. It'll be interesting to see how that minimum essential benefits is defined. It's being worked on right now. The Institute of Medicine has a work group, and there's discussions related to what the minimum essential benefit package will be for the state exchanges and for Medicaid. And once we know what that is, we can try to compare the level of services that we provide. But it's an interesting question because, you know, the Indian health system throughout its history and politics and congressional funding and funding distribution formulas has ended, and just history, has ended up providing different levels of benefits in different sites. And so, and then there's a certain level of appropriations each year, but the amount that we get if there are increases changes depending on the different formulas. And so one of the conversations in the past has been, should we start talking about a minimum essential benefits coverage in IHS? That's a very complicated conversation, and it's something that we need to be thinking about as we move forward with the Indian health system. So the real comparison that we've done so far is really just the expenditures, the spending on healthcare. We have the lowest. But in terms of cost-effective care, I think it's always good for us to be thinking how to provide care in the most cost-effective way, even though we still are the lowest funded system. How we compare to other insurances, I think it really varies. I hope that answered your question.
Thank you.
Okay. Next question.
I heard that during our last year's conference.
Sorry, can we ask people to state your name and your clinic when you...
My name is Britta Guerrero from Sacramento Native American Health Center. I remember last year there were some discussions about pay for performance, and for clinics that are exceeding, there would be opportunities for additional funding, and I wonder if that's still being considered. And then my second question is, with the ACOs and the exchange programs, if there's some way that IHS could actually influence the states and the exchange programs to include an Indian health provider within their network or their IPA and actually incentivize that partnership. I'm sure you're aware that the lack of specialty care in our communities is one of our major hurdles. And so if there's a way that we could be included in those ACOs and there would be some sort of incentive for including us, that would guarantee that we actually do have a place within those networks.
Great. Well, thank you for your comments. The issues of pay for performance, the conversations I've been in revolving the Affordable Care Act relate to sort of the accountable care organization conversations about groups of providers getting together, finding cost savings and improving quality, and therefore sharing in cost savings with CMS, with Medicare. And we're really interested in seeing how people think the Indian health system could fit into that sort of a framework. We're not really clear how we could, because we already receive preferable rates, and we may or may not be a part of the accountable care organizations, but we need to really look at that. The issue of the exchanges, I'm glad you brought that up. The whole issue of our Indian health providers going to be in the networks of the plans that are a part of the state exchanges and how to influence that. And that's something that we've heard a lot from a lot of our facilities, is how can we make sure that we're a part of those provider networks. And we're working really hard with the department to have conversations about how best to do that. We already have Section 206 of the Indian Health Care Improvement Act that guarantees us the highest in-network rate of reimbursement. So whether we're in the network or not, we're never going to get the highest rate. But you made a really good point. Being in the network is important because it might mean access to different specialty services that we don't already have. And that's a really important distinction. So thank you for that input. We've heard a lot from the tribal programs, this exact same input, and we really are working hard with the department as they're looking at this as how they're going to implement the state exchanges. I would encourage you to, when the notice of proposed rulemaking, the comment period comes out for the first part of the exchanges, to really take a look at that and see if the language in there makes sense and is what we need, and if not, please provide comments. So thank you. That's a really important point about the exchanges and the health plans that are going to be a part of it. Other questions?
Hello, Patsy from the Indian Family Health Clinic in Great Falls, Montana. I'm impressed with all the work you've done in the last couple of years. But now a huge part of being in the urban sites is the insurance for the providers of malpractice, the tort claims. And I know as an urban clinic, we're not IHS, so we're not federal. So, you know, supposedly we're contracted, but we're not a federal employee. So if we could be under those tort claims, then the specialty providers would be like your OBGYNs. We could have those. We can't right now, but there's no budget for that. Is that in the writing us in the terminology with NCUIH for the Affordable Care Act? Does that make us up there with the IHS then, so we could get that?
Phyllis Wolf, did the Indian Healthcare Improvement Act include any update on that topic? So urbans are not included, and it's because of their status as a contractor? They're just not included. Well, that doesn't make any sense. Well, anyway, I'm glad you let me know. I thought you were covered, so now I know, so I can start making that argument. So thank you for letting me know.
Okay, so we got Ralph, and then Marty, and then we're gonna have to probably wrap it up after that.
I just wanted to comment about that because community health centers got federal tort claims, but they had to buy it. They had to set up a special fund that was funded back in the, I think it was the late 80s or something like that, to get the Department of Justice to authorize coverage for the community health centers around the program. In fact, I think there's some concern right now that fund is being depleted, and so they're looking for additional resources in order to keep the fund up. So I think that was part of the problem, because we had asked a couple of years ago about why the urban programs, if you look at it, the urban programs are the only ones that are not included at this particular point in time. And then in talking with Dan Hawkins from NAC, he told me, well, we had to buy our way into this, and he said, you'll probably have to get an appropriation in order to be able to do this. So I don't know if that's still the issue or a concern or whatever the situation is, but it might be something, if we knew that was the avenue that we needed, then that would be helpful to us to be able to advocate on our behalf to try to get people engaged in federal tort. Because I think as time goes by, I don't see health insurance rates going down anytime soon, nor do I see tort claims and other kinds of liability insurances going down anytime soon. And that just eats into your limited budgets as it is. So.
Right. Well, I'm really glad you're all making me aware of this. I can't know everything about IHS. This is something I didn't know, and so it's important. We'll take it back and we'll look at what the legal issues are and try to figure out what the options would, like what is and you know, sometimes the laws are very hard to understand, but if there's a way to get it done, it just makes sense to me. But I'm totally naive, so I'll try to look into it and see.
I just have a question. You had mentioned under the Affordable Care Act, American Indian people would be exempt from the insurance penalty. And you defined it, what's the definition of the act for Indian people? Is it a member of a tribe?
Yeah.
And is it federally recognized or is it state recognized? Or could you clarify that for us? Thank you.
Well, the particular provision says members of tribes, and it references the IRS definition. And so I'm not a legal expert in terms of whether that means just federally recognized tribes, but
yes, I
it
think
may.
it is just federally recognized tribes.
Yeah, so I think that the IRS has been, is the one that's going to implement that particular part part of the Affordable Care Act, so if you have comments for them.
Will IRS come up with a definition who is an Indian?
So he just asked, will IRS come up with the definition of who is an Indian? Sorry, not everybody here.
It's in the law. And the law says members of tribes as per the IRS's definition. And so in terms of how they implement that, I think it's important that they hear your comments. There's probably going to be a notice of proposed rulemaking coming up on that. I don't know when, but that would be an opportunity to provide comments. Or there's someone named Christy Jacobs who's at the IRS. Christy Jacobs could give you more information about that. The problem with the definitions in the law is that if Congress were vague about it, it'd be a lot easier to change. But if Congress is very specific, referencing another law, that's the problem. It's very difficult to change it because the courts assume and everybody assumes that Congress meant for it to be that way. And it might not be what we wanted, or it may not even have been what they intended, but whenever legislation is passed, if it's very specific, the courts tend to rule in favor of the legislation because Congress intended it. If Congress had made it broad, then we would have been in a position to be able to change it. So that's the challenge we face here. But I encourage you to contact Christy Jacobs and IRS and ask her questions about it. There actually might be things on their website right now that are materials available to discuss it. So if you can't find them, contact Phyllis Wolf and we'll try to help find them.
I'll pay my taxes first.
Yeah.
Okay, so Carmelita, that's probably our last one.
Okay. Yeah, let's make sure we pay our taxes.
TTAG is trying to get them to accept all the definitions that are in the health reform and in the Indian Health Care Improvement Act, but there still has not been any decision from the IRS on what they're going to accept. But TTAG has been pushing Indian Health Care Improvement Act and health reform.
For the broad definition.
Yes.
And who would be the certifying agency for that?
That we haven't found out. That's being discussed with CMS. And whether they're going to do it, and then they said it may be IRS because some of it's a means test. So it's a lot of it's still up in the air.
For the Indian part, there has to be a certified agency because if we don't have one, then anybody can walk up and say I'm Indian.
Right, that's what we've said. Everyone in the United States will be Indian when they find out the benefits of it.
I can clarify. So all of the activity related to the state exchanges and health insurance coverage is really going to funnel through those state exchanges. And so the state exchanges are going to be responsible for enrollment and eligibility and whatever. The states are going to act based on regulations that are developed by the federal government based on what's in the law. And so the process is the law was passed and then the law has to be by Congress. So Congress made that decision about the penalty and member tribe and IRS definition and all those other conflicting definitions in the thing. Then it's the job of the executive branch, the administration, to implement the law into policy. And so federal agencies implement laws into policy through regulations or sub-regulatory guidance and our policies, our guidance. And so right now all of the activities of the federal agencies are focused on implementing the law. And so when you see a notice of proposed rulemaking on a certain topic, that's the federal government saying, here's what we're thinking, and we like your comment. And so I would encourage you to get more information on this topic. When the notice for proposed rulemaking comes out from IRS on this issue, because this particular issue is going to be an IRS issue, that's your opportunity to comment and to try to influence how the federal government is implementing the policy. And after the comment period, then the federal government puts in the final regulations, and then the states have to follow the final regulations. And so we're at the point to where Congress said what was in the law, And related to Indian definitions, there's a bunch of different definitions in the law, and that is something we've gotten a lot of input that people want to have changed. And so I can assure you that there's been a lot of effort and a lot of attention paid to this particular issue, the differing definitions in the Affordable Care Act. And there's people working very, very hard to try to find a way to resolve this issue. The challenge we're having is, you know, Congress was very specific in the law, and that's a big challenge. So I think the next, we've heard plenty from Indian country that those definitions need to be reconciled. So the administration is working very hard on trying to find a way to reconcile it. You'll probably see the outcome of that discussion in the notices for proposed rulemaking for the exchanges and for the IRS, the penalties and those sorts of things. Then it's your opportunity to comment on where the federal government's thinking before the final rules are put in place. So there's opportunities to comment along the way. But it's a very challenging problem. You know, I wish that there had been an opportunity to discuss this with Congress before they did that. If there had been no definitions of Indian in the law, it would have been a lot easier. And that's what happened with the Medicaid eligibility. They weren't definitions, so the policies could put the definition in place. This problem we have is Congress had very narrow, specific definitions in different places, and the tribes tell me that the way it happened at the end is they were throwing Indian provisions into the bill, and there was no time to reconcile them. And so here they are, and this is what we have. So I can reassure you we're working very hard to try to resolve that issue, and we've heard loud and clear from Indian country these definitions aren't necessarily the best ones, and they aren't necessarily, they conflict in places. And so it's the work of the administration to try to find ways to fix that, and I can tell you we're doing everything we can to try to do that. And we'll probably be able to update you on that sometime in the near future.
I'll ask Linda to introduce herself, and this will be our last question.
Hi, I'm Linda Stone from First Nations Community Health Source in Albuquerque, New Mexico. And I wanted to know if IHS would consider having discussions with the many partners that you're partnering with in terms of increasing the FQHC reimbursement rates for the urban programs, which is lower than what the tribes are getting. Because you know, we do provide a substantial amount of enabling services and case management and other services to our patients for which we don't get reimbursed for, and it's not reflected in the FQHC reimbursement rate, and this also gets to our need for sustainability as well.
Great, well thank you for making me aware of that. I had just emailed Mary Wakefield about an FQHC issue, so I'll make sure that I talk to her about this issue as well, and ask her, are there your questions, is there opportunities to discuss this issue about trying to get a better rate. So I'll talk with Mary Wakefield, who's the administrator of HRSA, about this issue, but this probably, does it involve CMS or the Medicare, Medicaid, or is this really, it involves them, it would involve them too, right?
I think it would, yeah.
So we would need to have CMS involved also. Has TTAC looked at this at all? Do you know the urban rate for FQHCs with CMS? No. Is this for Medicare, Medicaid, or both?
I believe it's for both.
For both.
Medicare and Medicaid.
Okay. All right. Then I'll talk with them and see if they've had discussions about this already, and if not, if there's a way to maybe convene with the urban organizations to talk about that. And remind me if you don't hear anything in a couple of weeks, because sometimes there's too much to remember. All right. Well, thank you so much for the opportunity to talk with you today. I know that there's a lot more we could talk about, but I'm really grateful to have the opportunity to meet with you. Again, I want to reassure you, you have my support and you have the support of this administration. And we're really doing everything we can to consider your issues as we move forward. And, you know, I just encourage you to keep sending me your issues. Send me letters, send me emails. You know, the conferring policy and the process we put in place will provide for a more regular way to get input from urban Indian organizations, but I really encourage you, don't be shy. Let me know what your input is, let me know what your questions are. It doesn't hurt to send me a letter. I get them all, and we address all of them. We're trying to keep up with them, but you know, if you don't get a response in a timely manner, please contact my office. And I just would really like to hear more about how you see your role as we move forward in this very interesting time in healthcare in the United States. So again, thank you all so much, and I look forward to a time when we can talk again. Thanks a lot.